Now, this is a SAMHSA-funded webinar through the Opioid Response Network, and the network assists states, organizations, and individuals by providing resources and technical assistance that they need to address the opioid crisis and stimulant abuse. And technical assistance is certainly available to support these practices. And this is all under the extraordinary vision of Catherine Cates Wessel, who serves not only as the president of the American Academy of Addiction Psychiatry, but also is the overall manager of this network with her excellent associates. So we're grateful that we are part of the Opioid Response Network, and we look forward to our continued work. This webinar is only a portion of what we do, obviously. So given that reality, we will get started. Once again, I think that this is a topic of great interest. We're going to hold the questions until Linda has completed her presentation. And this is simply a matter of making sure that she has the opportunity to present the full array of what she's got. And that's really important. Then, of course, Linda will be happy to respond to your questions. Linda serves as the president and CEO of Kodak, which is a large treatment system based in Rhode Island. She's got tremendous experience and knowledge in this area. And in addition, she's actually done this work. So this is a very practical sort of webinar. We've left the theoretical construct into how this actually gets done. Now, before I go on, it's important to commemorate this extraordinary day in American history, being September 11th, given the reality of what happened 23 years ago as our nation came under terrible and tragic attack. And I can tell you, since I'm based in New York City, our offices used to be directly across from the World Trade Center. That represented a terrible day, and one that was tragic and both infamous. So many people were died, and they had suffered in their families as well. So I wanted to express our remembrance of that day, which is memorialized, and that's already happening at the World Trade Center site, New York City. So to the webinar. I wrote the first article from our association's perspective about treating incarcerated people with medications, primarily methadone at that time. And that was written in American Jails Magazine in 2000, so 24 years ago. And that is extraordinary because it's taken a very long time for this to evolve. But I'm happy to say that correctional facilities are far more open to this than they have been in the past. And treatment programs have been successful in working with correctional facilities in different parts of the country. And we do have an international audience today as well. And I'm also happy to say that many of our international colleagues have been doing this work for many years, notably in different parts of Europe and in most especially in the early stages with Spain. So again, we're going from the theoretical to practical here. And I have to say that from my perspective, the more attention that is paid to this and our policy partners, both in the Opioid Response Network, in JCOIN, the National Institute on Drug Abuse, and SAMHSA, Bureau of Prisons, many of our policy partners and the Legal Action Center have really done a great deal of work over the years to increase access to care for inmates in correctional settings. So as I said, Linda Hurley is not only the president and CEO of Kodak. Lynn is also the board representative from the Rhode Island treatment programs to our association. And I'm also grateful for her work because she was just acknowledged at our national conference in Las Vegas just a few months ago in receiving the Nice Wonder Dole Award, which acknowledged her extraordinary achievements over the course of her professional career. I've known Linda for a great many years. She is a terrific person, as you will learn. She has great knowledge, but more importantly, she has great compassion for the people we treat. And there is a great need for compassionate care as we respond to the needs of the people who present for treatment. So Linda will speak to you probably for the next 50 minutes or so, followed by the questions that you have. This recording will be released to everyone with the information probably by this Friday afternoon. So this will be broadly disseminated as well. So with that, it's my pleasure to introduce Linda Hurley to you. You're going to hear a lot of great information. And so thank you again, Linda, for your willingness to share this with us and our colleagues. And so I will now stay silent until we get to the questions. It is now yours, Linda. Thanks so much.
And are we on, Nancy? Okay. Okay. So I'm hoping you can hear me. Is that so, Mark?
We can. Loud and clear.
Tremendous. Thank you. Well, first off, I have to thank you for that introduction, Mark. That was very kind. This is a real gift to me because I've been doing this actually for, I believe, 36 or 37 years. And the changes recently that have come about, at least in the United States, have been so heartening. We have come so far, and I am thrilled to be able to speak to you all about what we're doing here and what's working with the models and providing care, points of intervention in justice settings. So I'm going to jump right in because we have a lot to cover, and so I will do so. As Mark said, what we're doing today is really looking at implementation. So I'm going to give a very brief overview. Some of the slides that I'm presenting are slides that you will be able to present to others that don't have the same background. And I and our staff and others that have done consulting on this have these particular slides have been particularly successful in getting the concepts across that address stigma and bias. Of course, one PowerPoint isn't going to take care of stigma and bias, but there are a percentage of folks who just with information start to shift their positions. And that is remarkably important when we're working in criminal and legal settings. So we're going to just look at the opioid epidemic briefly, the evidence-based practice that we have in carceral settings currently, the medicines, and most importantly, the 4 principles that make medication-assisted treatment utilizing MAT, utilizing MOUD in carceral settings. So the principles that are evidence-based now, which I'm so excited to say. 4 different models of care because the principles don't have to be all within the same logistical construct. You know, if we're working in a prison that services 5,000 people, the same logistics wouldn't apply to 7 jails in a county, each with 2 people that are suffering from OUD and need their medicine. So we're going to look at 4 models of care. Lessons learned from the Rhode Island model and some lessons learned from the other 3 models, and then implications and next steps. The evolution of overdose death. If you can look at these 5 bars that run across. This is only to 2020. And they have all moved forward on an upward basis with fentanyl taking the lead. So this is just a view of what we're really looking at. these numbers also are from 23 and 20, you know, across the board. But what's important to see is that, you know, we know well over 100,000 people have been dying in the US annually. We also know that, at least in Rhode Island and across the nation, that a minimum of 1 in 4 people die within a very short period of re-entering the community following incarceration. So it's a highly vulnerable population. This actually, the 31% number, this study was done in Rhode Island, and it projected reduction in overall overdose death relative to medication-assisted treatment when people are incarcerated and then following up in the community as 31%. That percent has grown dramatically. And just in case you don't know this, risk of relapse 2 weeks, the 2 weeks following reentry, following incarceration is extremely high. And we've actually seen higher than 13 or 29%, or 29 times higher than the general population using. It's important to look at the connection between the criminal legal system and opioid use disorder. And so if you look at how much money, you know, is spent annually for one individual who is incarcerated, and then you look at the issues around diversity and equity, 10 times more people of color are incarcerated using drugs at roughly the same rate as those who are white. And the biggest number is $80 billion are spent on incarceration in the United States each year. It's a tremendous amount of money. And it looks that, you know, we have a pretty high percentage of the world population here. So this kind of progression that happens, like, you know, people recognize that they have this disease, this compulsion, the compelling nature of the substances they're using. And very frequently, it runs into incarceration. It's part of the process. So in 2018, greater than 75% of the individuals in prison in the United States were using heroin prior to their commitment. And if you go back to 2007, it was 33%. So you can see what happened over the course of 11 years. And then this is 5 years later. What's important here is that utilizing a lot of information from the World Health Organization, NIH, NIDA, National Institutes of Health, and the National Institute on Drug Abuse have endorsed the effectiveness. This is so clearly evidence-based now. They've all urged the correctional systems to provide incarcerated individuals with the same evidence-based treatment that they can have in the community. And I like these quotes. And they're very useful if you are looking at working in your system or helping other systems create one of these models or another model. You know, it's important to use the evidence-based. It's important to have the credibility that we need to share. And so feel free. That's why these slides are going to be available to you. One of the most important things to know is that we always get pushback whenever we go into any carceral setting. And, you know, there's some pushback from some departments, some folks, there's some bias somewhere, and we have it implicitly, we all do. And then we also have bias that has, been sourced by fear, and it turns into discrimination and prejudice. And there's always some folks that have that background. So what we need to address that this is going to happen. In Massachusetts, the Pesce case, Pesce, Pesce, the Pesce case found that not allowing someone to continue their medicine for opioid use disorder from the community once they're incarcerated is cruel and unusual. So we're breaking somebody's Eighth Amendment. So this is coming. And I think it's really important for everyone that participates in the implementation of one of these programs to know that it's coming. And knowing that it's coming, we can now offer people the opportunity to share in the benefits. So, there's been a number of RCTs, of evidence-based practices that have been, controlled trials that have been completed over the years, beginning in like 2010 even, and through till today. So it's easy to be able to say, this is the right thing to do scientifically, medically. And substance use overdoses go down, criminal behavior recidivism goes down, and HIV high-risk behaviors go down. And this is all stuff that you have references for at the end of this program. So those things we just talked about, I just talked about, like, why is medication-assisted treatment utilizing the MOUDs so hard to put in place? They're simply medicines. And one of the reasons is that the medicines are not understood and the disease isn't understood. So giving this next slide, I'm really excited to share with you. I've gotten such good reception from everywhere, from judges to security or uniformed professionals that are responsible for security and safety in the respective carceral settings. I get really strong responses, so I urge you to use it because it works. And this is it. So when we try to explain the disease, and this will allow people to understand the medicine as well, is when someone first starts, it's called being naive. They're naive to psychotropic substance of opiates. And so they use one night on a Saturday night, and they are enjoying it. And Sunday morning they wake up and they say, that was fun. And then they sort of forget about it. So the tide comes in, the tide goes out, tide comes in, tide goes out. The little footprints, the little pathway goes away. There's been no permanent change to the brain, no permanent progression from one space to the other that says, I liked it, but I need it. It's not there. Now, the top right, you're looking at using maybe 6 Saturday nights in a row. And you wake up on Sunday morning and you're thinking, I really, really like that. I think I want it. I want it tonight too. And maybe Monday morning, you don't even feel good because you've used 3 days in a row. And this little goat path, okay, it's getting stronger. It has a direct beginning and a direct end. So there is definitely a pathway in the brain that is saying, this, I do this, and I get this response. I like this response. Do that for a while. And now bottom left, someone is left with this little rural highway, and it has a deep foundation. It definitely knows where it's going. It's going from like 7 different spots in the brain, actually. It's created a new pathway to learn what you feel you need. And now it's started to be, I really do need it. And the brain is saying, you know what? You do need this. So way back here in the hippocampus part, that part is saying, you're going to be really sad if you don't have this. So That's a little bit deeper. And then you look over here on the bottom right, and the bottom right is a 7-lane highway, and it is in, it goes. The second you have a cue, or the second you see a spoon, or the second you see anything that reminds you of that substance, you are compelled. So the chronicity, you can see how the chronicity advances, right? And the medicines respond very often, not always, respond to the chronicity of the individual. So frequently we have learned and heard that naltrexone doesn't work very well with someone who is in the middle of chronic use, and they've been using for a long time. So just in general, okay, the reasons that we need to have all medicines available to an MAT program in prison, if possible, is because it can address this part's fine. This part, somebody might just need to move to Texas for a little while with Aunt Sally and get out of their peer group, or they might need a little bit of buprenorphine for a withdrawal protocol. Over here, we're looking at probably needing a withdrawal, some protocol maintenance and withdrawal. And here is definitely a methadone for the most effective. Doesn't mean, you know, a colleague of mine, Dr. Jennifer Clark, who was responsible really for allowing us to develop this program, said, you know, this is all well and good, but the best medicine is the one that the individual will take. So what we do is, you know, I don't want buprenorphine. I don't want methadone. I don't want Vivitrol. Okay, well, what do you want? You know, and if it's safe, we're happy to give it to you. And if it's not working for you, well, come on, we'll change it. We'll do, it's easy to change medicines. There's kind of a mythology about not wanting to change medicines for this disease. So I hope this was as helpful to you as it was to me. I love that one. And it's really good at letting people see why all the medicines are most effective to be available for individuals in carceral settings, in any setting, really. So it's hard to put in place because logistically, obviously, how, you know, what happens in the particular setting, and every movement in a carceral setting requires thought, time, and resources. So logistics is incredible. Stigma is remarkable across the board. And there is also a piece of, often, I've seen it so often, not an entire department, but there's some people that actually feel that individuals, you know, deserve to be uncomfortable because they brought this on themselves. So it's like a retribution piece, that withdrawal is just part of you having done the wrong thing and now being incarcerated. Those kinds of biases are harder to change, and they may never change. Diversion is real. It's more real in various states. It's more real in higher populations and urban populations. But it is a very, very real concern, particularly for safety and security. And the other reasons that it's hard is public will is perceived as not being present. Therefore, the will of our policymakers is perceived as not being present. So they're not going to have that will to make these changes. And that ends up having, you know, being difficulty in funding sometimes when you're looking at government budgets to fund. So facilities across the country are beginning to provide MAT, and they're happening at a much faster rate each year. It's really exciting. And they need to be based on 4 crucial principles. So the principles are, we provide all FDA approved medicines, if possible. And I know that there's many variations on and variables that come into this, not just having the funding, but all FDA-approved medications need to be available based on patient choice and clinical input to all that need them and request it, and to provide MAT for as long as anyone is incarcerated or as demonstrates need, regardless of the length of sentence. And there needs to be immediate follow-up for care upon release. Now that makes sense, right? Everybody talks about it. Warm handoff, hot handoff is now a phrase now. But immediate follow-up is necessary. And if you are looking at having a vendor relationship for your partnership in a carceral carceral setting, that needs to be a deliverable of your contract. Why do all of this when if someone's going to leave, might have a bus ticket, may not even have a place to live, and their brother or sister has said, we're having a party for you tonight. Where do you see what's, you've been gone 3 years. Where do you see what's been out on the street? And they can turn out to be one of those, 28 times greater mortality death following 2 weeks post-incarceration. So immediate follow-up is critical. So here's the model of delivery in carceral settings. Okay. Mobile medication unit will go to a jail and deliver the medication. That means they pull in and they pull into that section where of a parking lot that is secured, and security or safety and uniformed individuals bring the individuals out, and the vendor or the partner will administer from the medication unit. And this is great for, I've worked with people in the Southwest where, there's, as I said, like there was like 6 jails in a large county, and 2, 3, and 6 people in each of those. And they actually can go around, or they take 2 out in a day. And that's the method by which people can receive their medicine, because it certainly wouldn't be cost effective to set up an OTP in a jail with 2 people that need the medicine. Then medication is transported from the community OTP to the DOC for daily administration. And Kodak, we had done that in Rhode Island for, goodness, 10, 12 years, from 94 to maybe 2008. And you just bring the medicine and, all with DEA approved movement with the inventory, and the OTP actually hands off to the medical staff, who then take responsibility for it, and then they administer. So number 1, the OTP is administering. Number 2 model, the medical staff of the respective Department of Corrections does that. And then some Department of Correction some departments of correction license their own OTP program. And they do, it's all 100% OTP, soup to nuts, within the facility. That has proven to be a bit overwhelming. There's a lot that goes on in a prison or jail, and this takes a lot of time. And then the 4th is the one that I will talk to you about from Kodak, which is we're a partner, and we co-located one of our opioid treatment programs, DEA registered, SAMHSA approved, state licensed OTP and we dispense, administer the medication daily, along with providing all of the medical care. Okay, so let's start with number one. Checking my time here. The mobile medical unit, the modified van, it just goes directly to the jails, like I said. And most of these apparently do deliver buprenorphine to individuals. They're not a large number that deliver methadone. There's a huge amount of interest in the model because it's a good one, as I said. And we also have limited data, and we're really looking forward to having more. And so here, this Atlantic County Justice Facility have actually provided this in 2022. And they said, they do the daily methadone administration for anyone with opioid use disorder. They continue the medication during incarceration. They coordinate with the jail for screening and logistics, as opposed to having the vendor or the partner having their own doctor and nurse. And they serve like 450 people annually. This is good. Low threshold access reduces logistical barriers. And the cool thing is that they partnered with the community-based OTP, so that would assure that there would be the handoff, that would be continuation, continuity of care, same day as release from the facility to the OTP. Some of the challenges, are figuring, this is all new. So the logistical challenges are tough, and the funding challenges are tough. I think that the decrease in recidivism is exciting, and we look forward to seeing more of that nationally. Second model is in Vermont, and it's part of their hub and spoke, actually. The vendor provides couriered medicine to the facility. And the spoke, the facility, administers buprenorphine and naltrexone. Again, I'm hopeful that methadone is going to be employed more and more as one of the medicines, for obvious reasons we spoke about earlier. And then the hub are the community-based OTPs that provide the methadone. So it gets a bit trickier. It's more complex. It's wonderful that it services 650 patients daily. And this is what they have shown, that after the implementation of the program, 2017 to 2018, mid-year 2018 to 2020, the number of people that received MAT jumped from less than 1 to 34%. They increased the amount of MAT post-release, which is wonderful. That's absolutely wonderful. So it went, not only did the 34% be maintained, but there was another 6% that jumped up. And that's the difference between life and death with what, the adulterants that the street product currently hold. And they decreased the fatal overdoses from 27 to less than 10. So it was lovely. Again, all these they can be expanded, and we can take one at a time and look at, your individual logistical, geographic, cultural area to see, exactly which of these four principles can really be expanded upon, because if they're all four of them are there, it works. It works. So this one was the one in Franklin County, and this was really, really done well. We actually provided care in a neighboring county jail, and we saw as it moved. This is the third model of practice for medication provision. And it's the one where they approve their DEA registered OTP to be within the facility. So they were approved as an OTP in August of 2009. And prior to the licensure, the facility offered naltrexone and buprenorphine, I'm sorry. My apologies. The program emphasizes providing evidence-based care and supporting the transition into the community and continual support in the community. And that's a difference. They really did strong follow-up in the community post-reentry. It serves 40 patients daily and $27 a day. That does not include the overhead, administrative overhead, which, you know, brings things up quite a bit, which we'll see in model number 4. I want to just stress here when we say emphasizes holistic evidence-based care during incarceration. They took a truly holistic response. Several individuals in group therapy sessions to individuals, they had CBT, which most facilities do have, and real motivational interviewing and contingency management. And that was really great. Okay. Lessons learned. This was really hard, obtaining OTP licensure. And it's hard because if we're an OTP and we expand and we want to open another one in a geographic area that's underserved, it is easy enough for us to be able to do that because it's all we do. When one of these systems facilities, these carceral settings, they running small countries, and there is a great deal to do, and it unless they are really if they have a lot of support, systemic support and state support, this will work well. This is a big one, this third bullet here, importance of team-based approach with security personnel and medical staff. That's very important. And there have been no published outcomes since the facility became licensed. So we'll look at model number 4 here. I think I'm on time. This is a co-location of a fully developed DEA-approved vendor within a correctional facility. And this is the RIDOC, Rhode Island Department of Corrections, along with Kodak Healthcare and Brown University. And we became the first correctional system that provided comprehensive access to MOUD to people who are incarcerated. We actually we provided all 4 medications since 2015. And that was all 3, I'm sorry. And that was really, I said 4 because we also do the I'm sorry, the I didn't want to use, I want to use the generic words. We provide oral and Vivitrol for patients. So naltrexone, two formulations, and actually we now do 2 formulations or 3 formulations for buprenorphine. And so there we provide everything that is FDA approved. The Rhode Island setting and political climate was somewhat difficult to begin with. And it was difficult because our governor made an overdose prevention task force. And when she recognized that almost 25% of the overdose deaths were in a population who had recently been incarcerated, she promptly gave us, or she gave the Department of Corrections $2 million to do something about it. So this was not systems change 101. we had to do it backwards. And in addition, we had not a lot of states apparently have this, but our correctional system with security, uniformed professionals, and medical staff are unionized. So being unionized caused a bit even more of a pushback for many reasons. And I will share that with you. So in 2015, when when the Department of Corrections got the $2 million and we bid on it, and Kodak Behavioral Healthcare won it. We were awarded, and we subcontracted to Brown University to manage all of our data, evaluation and outcomes. We had the highest rate of illicit use among adults in the country, with 16% reporting illicit substance use in the last month, in terms of overdose death. So 21% of overdoses, and then up to 24% were recently incarcerated people, and 60% had criminal justice histories. Twice as many overdose victims were recently incarcerated. That's huge. So this was the Rhode Island strategic plan, and we included treatment, rescue, prevention, and recovery in our program. One thing that made it easier for Kodak and DOC and Brown to do this really special program was that we have a unified correctional system. So we don't have jails throughout Rhode Island in terms of, municipalities and counties. So we have everything on one campus. So everything from high security and maximum to minimum to medium to intake and women's are all on one hill. And right now we have an average daily census right now of about 2,400. It was well over 3,000 when we started. And what I think is most important on this slide is 50% of those awaiting trial are released within 6 days of commitment. And that, if you think about that, our program, in order for us to be an effective intervention, we needed to take it all the way back to the point of commitment. Because in terms of intervention, if someone is there for 2 days and they either make bail or they go out to a hearing and make bail in another way, we would lose that opportunity. But if they're there for 2 or 3 days and we can do an immediate evaluation and allow them to be part of an MAT program, they can feel the relief from withdrawal. And it will give them almost like a memory. This taste is a memory of, if I'm really sick again, I could do this. So it's a tremendously important point of intervention. And that is one of the reasons that we created the program to work in the way it did. If you're someone from a carceral setting looking to implement this, you have to find the right community partner. You really do. They have to respect the mission of community safety and security within the institution. We use this a lot, and the wardens that go out with us, or they go out now on their own to various jails and prisons to help with this, is that, good security is not versus good programming. It's the same thing. it's the same thing. We have, and it's important to be able to speak to that. This is a lot of what correctional staff will say, why prescribe medication if inmate has already gone through detox? And that is just, most people don't understand the difference between physical dependence and opioid or other substance use disorder, and the differences in the brain as shown by that slide that we talked about with the pathways. And that I found that to be really a successful thing to use when working with security. And then there's, the idea of the diversion. They've seen it smuggled in all different ways, and it has not been great. So the yeah, trying to find my word here for this one. So it's shifting. What actually happens is once this is implemented, security understands, and security feels the difference in their environment, because when people aren't in withdrawal, in this wherever they're committed at the jail, or if intake, and when people aren't crying and sick and yelling and frightened and all of the physiological stuff that happens with withdrawal, the environment changes dramatically. It really does. And security or uniformed folks really appreciate that change. And again, we can always give the numbers that this cost is much lower than what happens to taxpayers when someone continues to use. Bottom line, and this is it, when you're looking at individuals not particularly interested or very resistant to doing this, is that the federal court case is going to say you have to do it. So you could get sued for not doing this at all. I'm sitting here if you don't mind. I hope I am still visible to you. I think I am. Good. So it's going to happen anyway. So even if I don't like it either, folks, this is going to happen. So you can either help me write the story or help the system write the story, or somebody else is going to write it and they're just going to read it to you, and you're going to lose your power in any implementation. It also starts to, if we can start to say it just over and over and over, that the MAT program is just another program. It's just more medicine for a disease that many of us have. And it's also a medical decision. And that was one of the hardest things in Rhode Island for individuals to accept. And a lot of the reason that it was difficult in Rhode Island was because the union, doing what it does best, to try to protect its members, was definitely not for this. So they had a campaign against us implementing. So basically, a culture shift is always going to be required to one extent or another, and it's important to have staff buy-in. So I think most of you have, had the experience of what, I call systems change 101. And that is just what we have to do. So if the second that you think this is going to happen, it's time to bring people in. And I just love this. This is just a nice, a very nice quote that I put on things, on various forms and learning pieces for people to be excited about recovery happening in a correctional setting, to actually get excited about it. So this is it, the MAT principles that we talked about. We provide the services to, we provide MAT services, MOUD, to all individuals who need and are requesting treatment. And we provide those services regardless of sentence, whether they're there for 2 days or they're for 10 years. And I know that there's always the funding variables. There have been times where we had to curtail that and we had to withdraw people who had been sentenced for longer periods of time because we didn't have the funding. We aren't faced with that right now, and I'm really grateful for it. And we do have some almost like financial algorithms that we can share if you'd like. I think my email and number is on the at the bottom at the end of this presentation, that talk about which medicines cost how much and how you can extend that to be the full length of sentence. We provide all FDA approved medications for the opioid use disorder, and Kodak provides MAT services in corrections with the intention, and we do it, of transitioning individuals to a community-based provider. So if you've ever had the experience, if any of you are working in one of the systems, if you've ever had the experience of discharge planning, and you're calling the practice that say Linda Hurley is getting discharged tomorrow, and you call up and you say, we thought it was going to be next week, but Linda Hurley is getting out tomorrow and she wants to come see you, and this is in the community of her choice, you're her choice. And they say, oh great, can't wait to see Linda Hurley, we have an opening 2 weeks from Thursday. Well, that's that 2 weeks of extremely critical time for anybody who has been incarcerated with a history of opioid use disorder, right? So you need to have whoever your partner is, be responsible. That needs to be a deliverable. Be responsible for that individual, for their treatment, for their MAT, utilizing MOUD, their treatment. Sorry. Until you can facilitate, your partner, your vendor, the entity that you're working with needs to be able to hold that person, keep their treatment even, keep their treatment in order, keep their treatment continuous, and facilitate getting them to the community and the provider of their choice. It's just critical. So this is really, it's a very simple piece here about what it looks like. Someone's incarcerated. They're referred to the nursing intake or DOC referral or self-referral, all these ways. And if they've already been in treatment in the community prior to commitment, then it's very easy. Kodak staff actually collect the information from the outside treatment provider and recognize what their dose was when they were last dosed with any medicine, and they can have their dose within the same day or within 24 hours, and it just continues. And if someone has a confirmed use, either, I don't know, they had treatment, we could track it, they had some kind of charge that was related to their use. For a long time now, but we do utilize a medication first across the board, medication first model, so that a physical exam is a quick piece that is fairly easy to get done within the system. And all that needs to happen is we see that there is medical safety in providing this medicine for the individual. And then later on, the rest of what has to happen administratively can happen. If there's no confirmed active use, there's an eligibility assessment done, And we haven't had very many people ineligible, actually. We really haven't. But this is low barrier. We really want people to get the medicine. And then, of course, we also provide clinical, group, individual counseling, and peer recovery support services. So special considerations are very self-explanatory here. Yeah, I'll let you read that. And then Kodak provides treatment to all who need and are requesting. Okay. And we talked about why awaiting trial, sentence, probation, and parole individuals are so important. And again, this is reiteration, but it's so important. 50% of all the people that are incarcerated at the Department of Corrections are released within 6 days. So this is, again, it's a remarkable point of intervention. 78% are released within 31 days. So we have the opportunity to show them that relief and how easy it is to obtain it. And it's actually, it's such a gift. It really is for us. The average time for commitment from commitment to starting medication decreased by 43% from 7 days in 2022 to 4 days in 2023. Now we have same day of commitment, and sometimes to 2 days if we don't have a doc available, but that's honest. It's not often. Telehealth services are also conducted by other DOC providers, such as the psychiatrist or other physicians that aren't Kodak physicians, but DOC. And we work closely together with the department our mission here is the same, and it is to get medication first and allow people exposure to the medication and the treatment. We found that the amount of days that people are exposed to treatment, have treatment, experience treatment, correlates almost exactly to the higher the number of days, the more likely someone is to continue in treatment in the community. So, again, this is a little bit of reiteration, but it's very, very important to understand and be able to share with others that are ambivalent or antagonistic relative to this program, to see what a remarkable benefit it is. I'm just going to leave you with this. I'm not going to go through it all the way because I really do want you to have time for your questions. So, peer recovery support specialists are important. And as I believe you all know, this is not new news. And it's important for them to be culturally congruent. Again, I've talked to you about this. Sublocade is still well over $1,000. So if everyone wanted Sublocade, we would not be able to do it. I don't think the state would be able to do it. But so far, we've been doing a great job with providing just about everything. I don't believe we have anybody on the injectable naltrexone or the depot naltrexone. That has not been one. That's not a medication that when people are left to choice, that's not one that they frequently request at all. I believe that, our population is probably a bit skewed because by the time someone is incarcerated, generally, not always, nothing isn't always, but by the time people are incarcerated, they probably have a more chronic use. And when someone is in the midst of their chronic use, the naltrexone, whether it's injectable or oral, is not going to be particularly effective. It's not going to be effective. Yeah. All right. So what's important here is that just for you to see how it breaks down. But across the board, people are usually, again, it's that 60-40 and split a bit between injectable and oral or film buprenorphine. This is just the increase in the utilization of Sublocade. Again, I do need to talk about diversion. My apologies. I need to talk about diversion. It's important when you're introducing this to not take security's concerns around diversion lightly. And because it changes everywhere, and it's based on the culture in which the entity or the facility is located. Frankly, urban New York City is not the same as Rhode Island. That's one comparison, and Western Mass is not the same as Eastern Mass. And so it's across the country, that's going to be different. But diversion is always important. And so we've worked out a program that every single time something diversion is seen or referenced, there needs to be a report. And then there is a collaboration as we're integrating these missions between security, safety, and rehabilitation. We keep integrating the medical and we keep integrating safety and security. So here we have, over 100,000 doses. We had 67 reports of diversion, and we've worked it out really well. It's a strong program, and I'll be happy to give that to you as well, as if you would like. So discharge planning again is just so important. Second highest rate of community corrections in the country, and the third highest rate of probation supervision, which is just amazing to me. So I guess the point here is that the continuity also needs to happen. The continuity needs to happen with treatment, but it also the continuity needs to be supported if someone is being released into community corrections.
And Linda, this is Mark. I'm going to ask you to wrap up, so we have a number of questions coming in.
Okie doke. I think I can do that. Okay. This is cost is important. I just wanted you to see this. I put this in last night because I realized that, everything we do is not going to be available to everyone if the state is not supporting it. But again, I've given you other examples. There's much less expensive ways to do this. Our key results are really, we have we have a 92% follow up in the community if you include the individuals who had come into incarceration already on a community program utilizing buprenorphine or methadone. They followed through. So over 90% is what we have. Decline in mortality, everyone knows. Decrease in recidivism, which I think is really exciting. And again, I can give you more of this information if you'd like. This one slide, Mark, will be my last one. History of understanding your state's environment, flexible, understand systems change, competence needs to be respected in the communities you serve. You know, this is when you're picking a partner. Commit to comprehensive reentry services. Commit, flexibility, flexibility, flexibility. Vendors or partners need to know that you're going to have to think on your feet and shift. You know, your business plan is going to have to be able to move, meet workforce demands, and flexible again, and mission integration. Public safety, public health, you can read these. Four models, you know them now, and you can create your own. These are the references. And again, if you have any questions, please, you can reach out to me or to my assistant, Nancy Turner, and we're going to be more than happy to get back to you with any questions, or even if I referred that algorithm, anything you'd like to have. And thank you for your time, and I would love to hear your questions.
Okay, Linda. Well, thank you very much. And questions we do have, as the audience has learned, Linda is a terrific resource, and she and her associates will be happy to respond to the questions you have. Again, I say to you that you're going to have access to this material and all of the slides by this Friday. So you will have that too. So now, Linda, to the questions. So what would you advise sheriffs when they indicate that they would like to give Vivitrol before an inmate is released back to the community as a method of decreasing post-release mortality?
Well, I think it's great. I know that I always, stress that the having 3 meds available is always good, even if it's for one day, but you have what you have. And if an individual is willing and wants to have Vivitrol and has cleared their whatever they had been using, then that would be absolutely wonderful. I mean, it's people have been in Massachusetts, I believe, UMass Chan, a medical school there, did a lot of work in Western Mass, just utilizing the Vivitrol as a medication prior to release. So I would recommend using it. Find a provider, a medical provider that is informed, and go for it. I think that's great. You're going to meet the least resistance across the board. And
okay.
That'll buy some people time, it's great.
Okay, as it relates to the use of methadone particularly, the question comes in is there doesn't appear to be any end stage for methadone treatment per se. And so basically the question is, well, when you're using medications like methadone, is it going from one form of dependence to another? So what's your guidance on that?
Okay. It is going from one form of dependence to another. The reason that methadone works so very, very well is because it is exactly like the opiate that someone had been using illegally, illicitly, or on their own prior to incarceration or prior to coming to treatment. That's why it works so very, very well. And for many, many people, they are happy to continue to use that medicine of methadone for the rest of their lives, just like they are happy to continue their statin for their cholesterol, high cholesterol. Other people, we found, and this has been researched for 40 years. Skip, so sorry, excuse me. For other people, maybe being in treatment 2 years, 3 years, and slowly withdrawing from methadone is what works. And other people say, I don't want this anymore. I want to try buprenorphine, and we can do that. We can get them to the level of methadone that is a dosage that's working for them, and they get to a level where the buprenorphine will then start to work. There's many methods by which to do that. I could give you 3 hours on it. It's lots of fun, but it does work. And so there's something for everybody. There really is. We need to expand our look at what the medicines are. And we need to expand, at least I needed to, and others here needed to expand our perception of how much control we had over what individuals wanted. But honestly, there are very many people that go for years without wanting to rock the boat because they got their lives back. They have full lives, and they just take their medicine every day. And they have 28 doses to come home with, and they take them, and once a month they go and get their next batch. It's really individual. I think I answered your question. I get tangential, I get excited, I'm sorry.
It's okay, and you were not tangential in the slightest. So there's a question about, I know you've touched on this, the question talks about recommended plans for follow-up after the individual has been released and out back in the community.
The recommended plan is that, number one, would be great if discharge planning could connect someone the day after or the day of release. This is a critical time. And you know how I showed you the slide with the 2 weeks. Each day you get closer to 2 weeks, then 10 days, then 8 days, then each day is higher risk, as shown by the overdose deaths. So if we need for individuals to get connected to their medicine the day or the day after they are released. How to recommend that? Discharge planning. We start discharge planning actually at the point of commitment in certain ways, and then we expand it as it goes, and if somebody's sentenced or not sentenced. But it's really important to have that connection made so that someone can get to a treatment provider, because it's difficult. All of us, I think, across the country have trouble just getting a primary care appointment, let alone trying to get into a private practice buprenorphine clinic or something like that. So that's it. The discharge planning piece of your program needs to be tight. And I know that's hard because people get, you think you're going to get released next month and it's going to be next week. Then there's good time. Then there's 4 days and 3 days, then 10 days. I know it's hard. But that's also, the peer recovery support specialists are very helpful in doing that bit of management with the patient.
Okay, thank you. Next is that the question is based on what you were presenting, were the individuals already receiving medication-assisted treatment prior to incarceration, or did they begin medication-assisted treatment during incarceration, or is it both?
It's both. It's both. So if you have a chance to look at the slides, I know I was moving rapidly. I'm sorry. I always want to say too much, but if you look at the slides, the one that says commitment, like this is what's going to happen. The one on the left-hand side, the little flow chart, when people are already utilizing methadone, buprenorphine, or Vivitrol in the or naltrexone in the community, it's very easy when they're committed. We know that day, and we can get from their clinic in the community, get from that clinic all of the information we need to safely dose them the next day, so there's no break in the action. And then if someone comes in withdrawal or reporting that they are have this opioid use disorder, The nurse gets that information. The nurse at commitment gets that information. And this is a good story, actually. When we first started the program, we got real fancy because we had Brown University and we were kind of excited about that. And so they got money for iPads and they were going to have all this stuff happen at commitment. And they flopped miserably. I mean, when people are committed, they are not happy. They're scared, they're mad, they're 100 different things, but they're not going to sit with an iPad that some of them have never seen before. So we went from all of that to having the nurses ask 3 questions. You know, have you had an opioid use disorder? Do you feel you do have an opioid use disorder? And would you like to have care? Three sentences or 3 questions at commitment, and it gets directly to the Kodak staff there, and we move the process along.
So thank you. It's another question that's come in about recommendations about people coming into the facility. They're using methadone at an OTP prior to incarceration. But the question is, suppose they're also using benzodiazepine. What, and if the facility has concerns about that, so how would you address that?
Well, we work closely, our medical folks work really closely with the DOC medical folks. So if someone is using benzodiazepine and they also have opioid use disorder, we would treat it exactly like we would treat it if somebody walked in the clinic, in the community, into our health center in the community and said, I need help, I want methadone, and I don't want to give up my Xanax. And so we look at that, you know, you assess the people, and what is medically kind of cool if someone's incarcerated is that we get to see them 24/7. So the risk isn't as great. It's great, you know, I mean, there could be diversion, there could be any number of things. So we would start very low with methadone, particularly if somebody was showing symptoms of withdrawal, and we don't want to withdraw. You know, it's the same almost conundrum that we have experience in the community, and so you go safely, you know, and safety just means you start as low as you possibly can, but still try to alleviate most of the withdrawal symptoms. And at the same time, you don't want to take away the benzodiazepines and throw somebody into withdrawal for benzodiazepine withdrawal. So it's same management, and most of our docs are familiar with that, you know, to the balance. And it's, again, it's easier actually because we can view them 24 hours.
Okay. Also, a question came up of, since you raised it in your presentation, what were the unions opposing this in Rhode Island? Why did they do that?
Number one, it was a bit of a, it went by steps. First, it was too much work. There was, you know, understaffing of security and safety. And every time, and truly, rightly so, every time someone who is the responsibility of the carceral facility moves from one spot to another, there has to be 2 individuals. So, you know, having med lines, additional med lines for methadone, additional med lines for buprenorphine, you know, that means more work. And so they were opposed to it because that, you know, you're going to work our guys, our folks, our members extra hard, and we don't want that. And then on the flip side, we had to bring our nurses in to create the dosages, etc. And they were angry because that meant that their nurses couldn't do it, but they had never done it before, but that their nurses couldn't do it and they would be deprived of overtime. Now, I know that might sound silly, but I have to tell you, this was real, and our unions are strong. I mean, they put billboards up to scare people on I-95. And so it was a battle, and we didn't want it to be, you know. So we kind of won over the staff before we won the union over. And we won them over because the director of the Department of Corrections said, you're doing it. So we did this backwards version of systems change, and we engaged, and then they just saw that, particularly at intake, which is like our jail combined, the environment increased exponentially without people being in withdrawal, both physically and the environmental and emotional component. So that's
So,
what they were fighting against. They were fighting for their members, which I believe that's what a union should do. But these were the two main things that they were arguing with us about.
okay, helpful to know. Another question is, what has been done with regard to telemedicine with this population, if anything?
We now do our methadone intakes, and we had been doing the buprenorphine uh, telehealth. So that's how we got to this 2-day, 1-day period of being able to start someone on treatment right away, like medication first and medication right away. So as long as there is a nurse present to sit with, or a provider of some sort, or some credential present to sit with the individual and speak and be viewed through telehealth with one of our docs, we can have that intake, what they call intake assessment, but it's really a physical, and it works beautifully. I'm grateful for this shift because it's really, we don't have people waiting 4 days to be able to see a doctor in agony.
And the question is, do the incarcerated folks get counseling and other services in addition to the medication?
Yes, they do. They regular group counseling. I think we have the availability depending upon where someone is, because there's a lot of buildings there. But at intake and minimum, there is a high amount of, there's a high census for folks receiving these medicines. So we can have up to 3 groups available a week for them. And we also provide individual counseling and the discharge planning to assure that people would move into treatment directly from their reentry into the community upon release.
And there's a question about the therapeutic dosage range of methadone hydrochloride for these individuals. I know it's been established as a range of 80 to 120 milligrams of methadone per patient per day, but I know that's also changed in an era of fentanyl where the stabilization doses are far higher. But the question is, what are the methadone dosage ranges for these individuals that you've talked about?
It is the same as in the community. The individuals that are being committed and coming into the correctional system are using the same medicines as individuals that are coming into an outpatient opioid treatment program. So the ranges are exactly the same. We pay attention every day to their, it's actually a bit easier to gauge because we can hear from them every day. But we pay attention and make sure that someone's comfortable. And occasionally we do the peak and trough. We don't do it as frequently as we used to because we found it really isn't necessary, but sometimes it is. The blood work that for when you have the least amount and when you have the most amount of methadone in your bloodstream with the 4-hour differential in there. And that range is supposed to indicate that an individual should be somewhat comfortable. But generally speaking, people want to be comfortable. But so it just, sometimes people say that they want to be lower, they want to be higher. And especially if you're in a setting where you don't have a lot of stimulation, you pay a lot of attention to your medicine. But this is really clinical. It's just clinical. When you have individuals that are working with you as providers and prescribers, they work with individuals for them to be comfortable. But the range is the same, and it's getting higher and higher. Because if somebody's been using fentanyl only for 3 months and comes into a community health clinic, and somebody's been using fentanyl only for 3 months and come to commitment in a carceral setting, their bodies are experiencing the same thing. So we treat them the same.
So, and I think that, for those listening, it's important to understand that fentanyl does create particular clinical challenges in stabilizing the patient. It doesn't mean that you don't do everything you can. It means you have to be attentive to the needs of the individual. And so for those who have other questions that have not been answered, I assure you we are going to send those questions to Linda, and we will be sure that she can get responses to you. Just given limitations of time, obviously, we could not cover absolutely everything. And for that question that came about, would we cover the Part 8 rulemaking from SAMHSA during this? We did not, because we had to focus on the topic at hand. However, ATOD will convene more webinars with regard to Part A rulemaking and compliance. I know that SAMHSA also plans on regional meetings as well in order to respond to questions. As Dr. Olson, the CSAC director, said during our recently convened conference, they recognize this as a very significant cultural shift and how programs will inevitably adapt. Also, it's important to keep in mind on Part 8 rule changes that you need compliance and alignment with states, both in regulatory authorities and Medicaid reimbursement. So to wrap this up, again, there will be available certificates of participation if you would like it. There is a brief survey at the end of this, which is now happening soon, so you can respond to the survey questions, and then that guides us in the future. So for now, I just want to thank Linda once again for her being so generous with her knowledge and her time, because you have to prepare for this, obviously, and you will get the slides that Linda has presented. I also want to thank the Opioid Response Network and SAMHSA for their ongoing support and funding for this, because without that funding, we can't not get this done. And frankly, to my own associate here, Angelina Budia, who manages all of this as part of her overall responsibilities. Again, I thank you. This takes a good deal of coordination. I hope this has been useful, certainly to people who participated, and you will have access to this information by this Friday, including this recording and including the slides that Linda had showed. So thanks again. Thank you for your time, your commitment to this work, which is great and it's ongoing. So I hope this was helpful. And Linda, thank you once again. It was very helpful.
Thank you.
Be well.